When was the last time your doctor sat with you for more than 8 minutes and actually asked you about every pill you're taking? Not just the prescriptions, the ones over the counter too. The ibuprofen you reach for when your knee flares up at 3 in the morning. The naproxen you've been taking with your coffee every single day for the past 2 years because it's the only thing that makes the morning stiffness bearable. The aspirin you've been told for decades is practically a health food. I'm not here to attack your doctor. I am a doctor. And I can tell you honestly, the conversation you deserve about these four medications almost never happens in a clinical setting. Not because your physician doesn't care, but because there are 11 minutes on the clock, three other patients waiting, and the research on what these drugs do specifically to a body over 60, to your kidneys, your gut lining, your cardiovascular system, your bone density, is scattered across journals that most practitioners simply don't have time to read. What I want to talk to you about today is a biological process happening right now in your digestive tract, a process these medications quietly accelerate, and one plant compound derived from a bark most people have never heard of that does something to that process that the pharmaceutical model has almost entirely ignored. By the end of this video, you will understand exactly why these four painkillers hit differently after 60, what the mechanism is that your body can no longer compensate for, and what a safer, evidence informed path forward actually looks like. Specific, practical, and doable starting tomorrow morning. Tell me your first name and where you're watching from in the comments. I read every single one, and it matters to me to know who I'm talking to. Stay with me, this one is important. Here is what almost no one explains to you, and it changes everything. Your gut lining is not a passive barrier, it's an actively maintained structure, one single cell layer thick in places, and it depends on a family of compounds called prostaglandins to stay intact. Prostaglandins regulate the mucus that coats your stomach wall. They control blood flow to the lining of your intestines. They signal your tissue to repair itself when it's been stressed. Now, here's the problem. The four painkillers we're discussing today, and I'll name them specifically, belong to a class called NSAIDs, non steroidal anti inflammatory drugs. Their mechanism of action is to block an enzyme called cyclooxygenase, COX for short, which produces prostaglandins. That's how they reduce inflammation. That's how they reduce pain. They interrupt the prostaglandin pathway, the same pathway that protects your gut lining. A landmark paper by Wallace and Granger, published in Gut in 2011, mapped this mechanism with precision, showing that NSAID use doesn't just irritate the stomach the way we were taught in medical school. It degrades the mucosal barrier at a structural level, and critically, the damage extends well past the stomach into the small intestine, an area that doesn't show up on a standard upper endoscopy. Think of it this way: your gut lining is like a freshly plastered wall. Prostaglandins are the team that maintains it, patching cracks, sealing gaps, keeping it weatherproof. NSAIDs dismiss the maintenance crew. And a wall without maintenance in a body under constant physiological stress doesn't hold. After 60, this matters more. Your baseline prostaglandin production is already lower than it was at 40. Your gut motility has slowed. Your mucosal repair cycle takes longer. So, the same dose of ibuprofen that gave a 45-year-old a mildly irritated stomach gives you a fundamentally compromised gut barrier with systemic consequences that include increased intestinal permeability, altered immune signaling, and accelerated kidney stress. No wonder nothing has worked the way you were told it would. Painkiller, risk factor number 6: aspirin, the trusted betrayal. What it does to your body? Aspirin is unique among NSAIDs because it acetylates COX-1 irreversibly. That means it doesn't temporarily suppress the enzyme. It permanently disables each COX-1 molecule it contacts. Your body has to synthesize new enzyme molecules from scratch to restore function. In your stomach lining, which cannot make new platelets as fast as younger tissue, this translates to a prolonged window of vulnerability. The mucosa bleeds more easily. Microerosions form, and because aspirin's effect on COX-1 is permanent until new cells form, Even a single daily low dose aspirin, 81 milligrams, sustains this suppression continuously if taken every day. The research. A large observational analysis by Lanas and colleagues, published in the American Journal of Gastroenterology in 2006, found that low dose aspirin users had a significantly elevated risk of upper gastrointestinal bleeding compared to non users, and that the risk increased substantially when aspirin was combined with other NSAIDs or anticoagulants. That is an observational study, not a randomized controlled trial, so we hold that appropriately. But the signal is consistent across multiple databases. The fatal mistake. The fatal mistake is believing that enteric coated aspirin protects your stomach. It does not protect your stomach. It simply delays dissolution until the small intestine. The systemic COX-1 inhibition still happens. The prostaglandin suppression still happens. The coating changes where the tablet dissolves. It does not change what the drug does once it's absorbed. If you're taking aspirin for cardiovascular prevention, step 1, do not stop aspirin without talking to your physician first. That conversation is non negotiable and I mean it. Step 2, ask specifically whether the 2018 ASPRI trial results apply to your situation. That trial found that in healthy adults over 70, daily aspirin produced no reduction in cardiovascular events, but a significantly increased bleeding risk. Step 3. If your doctor confirms you do need it, take it with a full 250 milliliters of water, never dry, and never on an empty stomach. Step 4. Separate it by at least 4 hours from any other NSAID. Honest timeline. If aspirin is genuinely unnecessary for you and you stop it under medical guidance, some gastric symptoms may ease within 1 to 2 weeks. Mucosal integrity repair takes 4 to 8 weeks. Painkiller risk factor number 5, naproxen, the long shadow. What it does to your body. Naproxen has a half-life of 12 to 17 hours, more than double that of ibuprofen. That sounds like a convenience. Take it twice a day instead of 4 times. But what it actually means is that your COX suppression never fully lifts. There is no metabolic window during the day when your prostaglandins recover. Your kidney blood flow, which prostaglandins regulate directly, stays compressed. In a person over 60 whose kidney filtration rate is already declining by roughly 1% per year, this sustained suppression is not trivial. The research. A study by Bombardier and colleagues published in the New England Journal of Medicine in 2000, the Vigor trial, examined gastrointestinal outcomes in NSAID users and found naproxen associated with a 4 times lower GI complication rate than rofecoxib. But that comparison has been misread. Compared to placebo or no NSAID, naproxen's GI risk remains significant. That was a randomized controlled trial, which gives it more weight. But the population studied had rheumatoid arthritis, so we hold extrapolation to general seniors appropriately. The fatal mistake, taking naproxen at night to let it work while you sleep. Because of its long half life, a nighttime dose means peak systemic concentration hits during the hours when your blood pressure naturally dips, and kidney perfusion is already at its lowest. This is precisely when sustained COX suppression does the most renal damage quietly and without symptoms. The exact protocol. Reducing harm if naproxen is needed. Step 1. Take it earlier in the day with food and with a full glass of water. Step 2. Use the lowest effective dose for the shortest possible duration. This is official guidance that is almost never followed in practice. Step 3. If you take it more than 3 days per week consistently, ask your physician to check your creatinine and eGFR every 6 months. Step 4. Never combine it with a diuretic. The combination is nephrotoxic in a way that the drugs separately are not. Honest timeline. If you reduce frequency, kidney stress markers can begin improving within 2 to 4 weeks in mild cases. Deeper renal function recovery depends entirely on baseline status. If you're still with me and finding this helpful, type the number 55 in the comments. It lets me know you're watching and it genuinely shapes what I cover next. Painkiller risk factor number 4. Ibuprofen, the kitchen cabinet danger. What it does to your body. Ibuprofen is probably in your medicine cabinet right now. It's sold as Advil, Motrin, and dozens of store brands. It's available without a prescription, which creates a psychological impression of safety that the pharmacology does not support, especially after 60. Ibuprofen inhibits both COX-1 and COX-2. COX-1 protects your gut. COX-2 is involved in inflammation and pain. But COX-2 also has a protective role in your kidneys, specifically in maintaining blood flow under stress. When both pathways are suppressed simultaneously by ibuprofen, your kidneys lose two protective signals at once. In a dehydrated older adult, which describes most people over 60 who don't drink enough water, this is a setup for acute kidney injury that can come on within days. The research. A nested case control study by Huerta and colleagues published in the British Medical Journal in 2005 found that current ibuprofen users had a meaningfully elevated risk of acute renal failure compared to non users, with risk rising significantly at higher doses. That is an observational study, not a clinical trial, so we hold that appropriately. But the dose response pattern they identified is biologically coherent with what we know about COX-2 renal function. The fatal mistake: taking ibuprofen with a cup of coffee in the morning on an empty stomach. Coffee is a mild diuretic. An empty stomach means faster absorption and higher peak concentration. And morning is when many older adults are at their most dehydrated, having gone 7 or 8 hours without water overnight. This combination, dehydration plus diuretic plus empty stomach plus full dose ibuprofen, is exactly the scenario that precedes acute kidney events. The exact protocol: if you must use ibuprofen. Step 1. Drink 400 milliliters of water before taking it, not after, before. Step 2. Eat something first, even if it's just a small piece of toast. Step 3. Use 200 milligrams, not 400, as your starting dose. The label maximum is not your recommended dose. Step 4. Do not take it 2 days in a row without a 24-hour break. Step 5. Never take it if you are also on a blood pressure medication called an ACE inhibitor or an ARB. The combination dramatically amplifies kidney risk. Honest timeline. If you stop unnecessary daily ibuprofen, some people notice improved morning energy within 1 to 2 weeks. Kidney function is metabolically expensive to maintain under stress. Lab improvements in mild cases may appear within 4 to 6 weeks. Painkiller risk factor number 3. Acetaminophen, the hidden ceiling. What it does to your body. Acetaminophen, sold as Tylenol, is not an NSAID, which is why I am addressing it separately. It does not suppress prostaglandins meaningfully. It does not damage your gut lining. Many physicians recommend it for this reason in older adults, but it has its own specific danger that is dramatically underappreciated. It is metabolized almost entirely by your liver, and one of its metabolic byproducts, a compound called NAPK, is directly hepatotoxic at elevated concentrations. Your liver neutralizes NAPK using glutathione. After 60, baseline glutathione levels decline, and critically, the 4000 mg per day maximum printed on the label was established for healthy younger adults with robust glutathione reserves. For many older adults, the true functional ceiling is closer to 2000 milligrams per day. The research. A prospective cohort study by Watkins and colleagues published in JAMA in 2006 found that healthy adults taking 4 grams of acetaminophen per day, the labeled maximum, showed significant liver enzyme elevations within 2 weeks. That was a controlled clinical study in healthy adults, so the finding is meaningful, and it strongly implies that the labeled maximum is not appropriate as a casual daily target. We hold appropriately that individual variation is significant. The fatal mistake: not accounting for hidden acetaminophen in combination products. NyQuil, Dayquil, Theraflu, Excedrin, most prescription opioid combinations, they all contain acetaminophen. A person who takes two regular strength Tylenol in the morning, a dose of NyQuil at night, and two Excedrin in the afternoon has exceeded the safe daily dose without ever opening a pain reliever bottle. The exact protocol: using acetaminophen safely. Step 1. Read every label in your medicine cabinet and identify everything that contains acetaminophen. The ingredient name may also appear as APAP or paracetamol. Step 2. Set a personal daily ceiling of 2000 milligrams and track it. Step 3. Take it with food and space doses at least 6 hours apart. Step 4. If you drink more than one alcoholic beverage per day regularly, discuss acetaminophen use specifically with your physician. Alcohol depletes glutathione and changes the risk calculation substantially. Honest timeline. Liver enzymes that have been mildly elevated from excessive acetaminophen use can normalize within 3 to 6 weeks of corrected dosing in most cases without pre existing liver disease. Painkiller risk factor number 2: the combination effect. When 1 plus 1 equals 5. What it does to your body. This one isn't a single drug. It's the pattern that may be the most dangerous thing in your medicine cabinet, and it almost never gets discussed. Taking two or more of the drugs on this list simultaneously, or in rotation within the same day, produces pharmacological effects that are not additive. They are synergistic. Two NSAIDs together don't double your COX inhibition. The interaction at receptor sites compounds in ways that amplify gut damage, kidney stress, and cardiovascular risk disproportionately. The clinical term is polypharmacy related NSAID toxicity, and it is so common in adults over 60 that some emergency physicians describe it as an epidemic that simply doesn't have a face. The research. A systematic review by Lanas and Garcia Rodriguez, published in Therapeutic Advances in Gastroenterology in 2010, found that concurrent NSAID use was one of the strongest independent predictors of serious gastrointestinal complications, more predictive than individual NSAID dose or duration. That is a systematic review of observational studies, not a trial, so we hold that appropriately. But systematic reviews represent our best aggregated signal. The fatal mistake: treating the morning ibuprofen and the evening naproxen as separate decisions made for separate reasons. They are not separate. Your kidneys, your gut lining, and your cardiovascular system experience them as a single sustained assault. The exact protocol: auditing your current regimen. Step 1. Write down every pain related medication you take in a 72-hour window, including the ones you take just sometimes. Step 2. Bring that list to your next appointment and ask explicitly: do any of these interact in a way that compounds kidney or gut risk? Step 3. If you are managing chronic pain and need daily relief, ask specifically about a single agent approach at the lowest effective dose rather than rotating products. Step 4. Ask about a referral to a pain specialist who has time for a real conversation. Honest timeline. Reorganizing from a multi NSAID pattern to a rational single agent protocol with appropriate medical guidance can produce measurable improvements in kidney markers and GI symptoms within 4 to 8 weeks. Type the number 22 in the comments if you're still here. It genuinely helps me understand who this is reaching. Painkiller risk factor number 1: chronic daily use, the pattern that rewires pain. What it does to your body. This is the one I want you to sit with. It is not about any single drug. It is about what happens when any painkiller, prescription or over the counter, becomes a daily ritual rather than a response to acute pain. There is a well documented phenomenon called medication overuse headache, but the underlying neurological principle extends beyond headaches. Chronic analgesic use, particularly with NSAIDs and acetaminophen, can alter the central sensitization pathways in your brain and spinal cord that process pain signals. Your nervous system begins to lower its pain threshold in response to the constant chemical interference. The result is that you need more medication to achieve the same relief. and your baseline pain level without medication rises. This is called central sensitization, and it is one of the most underdiagnosed contributors to chronic pain in older adults. And here is the compound, the bark extract I mentioned at the beginning. It is called Boswellia serrata, derived from the resin of the Indian frankincense tree. It contains a group of acids, boswellic acids, that inhibit a different inflammatory enzyme called 5-lipoxygenase or 5-LOX. This pathway runs parallel to the COX pathway but is not touched by NSAIDs at all. Boswellia, in some research, modulates this pathway without suppressing prostaglandins, meaning it may address inflammation without dismantling the gut protection system that NSAIDs destroy. The research. A randomized controlled trial by Kimatkar and colleagues published in Phytomedicine in 2003 found that patients with osteoarthritis of the knee who received Boswellia serrata extract reported significant reductions in knee pain and swelling compared to placebo, with a crossover design that strengthened the signal. That is a human clinical trial which gives it more weight, though the sample size was modest at 30 patients, so we hold the magnitude of the effect appropriately. The fatal mistake: buying a Boswellia supplement without checking for AGBA content. AGBA, acetyl 11 keto beta boswellic acid, is the specific boswellic acid with the strongest research signal. Many inexpensive supplements contain Boswellia powder with minimal AGBA. Look specifically for a standardized extract listing at least 10% AGBA on the label. The exact protocol. Step 1. Choose a Boswellia serrata extract standardized to a minimum of 10% AKBA, 300 to 400 milligrams per dose. Step 2. Take it twice daily with a meal that contains fat. Boswellic acids are fat soluble and absorption increases significantly with dietary fat present. Step 3. Give it 6 full weeks before evaluating. This is not a drug. It does not have an hour 1 effect. Step 4. Use it as a complement to, not a sudden replacement for, any medically necessary medication. Discuss with your physician. Honest timeline. Some people report reduced joint stiffness within 2 to 3 weeks. Meaningful changes in baseline pain patterns typically emerge at 6 to 8 weeks of consistent use. Do not evaluate at 2 weeks and conclude it isn't working. Let me give you something you can write down or take a screenshot of right now. Every single morning, non negotiable, Boswellia serrata extract, 300 to 400 milligrams, standardized to 10% AKBA, taken with breakfast that includes at least one healthy fat, a drizzle of olive oil, half an avocado, a small handful of almonds. This is your anchor. Daily, if you are currently using any NSAID, drink a full 400 milliliters of water before any dose. Never on an empty stomach, never with coffee as your only morning liquid. Track your doses, actually write them down for 1 week so you can see the pattern. 4 to 5 times per week, review the combination. On any given day, are you using more than one pain related product? If yes, that is the day to call your pharmacist, not your doctor. Pharmacists are often better positioned to catch NSAID interaction risks than busy physicians, and the call is free. 3 times per week minimum. Movement that generates synovial fluid, the natural lubricant of your joints. Walking, swimming, gentle cycling. This is not inspirational advice. Synovial fluid is produced by joint movement. Sedentary joints produce less of it. Pain increases. NSAID use increases. The cycle tightens. Now, the mistakes that will quietly eliminate your results. 1. Stopping Boswellia after 2 weeks because you don't feel different yet. 6 weeks is the minimum evaluation window. 2. Continuing to take two different NSAIDs on the same day while adding Boswellia. You cannot supplement your way out of a polypharmacy problem. 3. Taking any supplement or reducing any medication without telling your physician. That conversation protects you. 4. Evaluating based on your worst days. Pain is variable. Track your average week, not your hardest morning. I want to say something directly before we finish. If your pain is worse than it was 5 years ago and you've been doing everything right, it is not because you are falling apart. It is not because aging simply feels like this and there's nothing to be done. In many cases, the tools you were given to manage that pain have quietly contributed to the biological environment that makes it harder to feel better. We are living inside a medical and food system that was largely designed around a 40-year-old male body. The drug dosing, the risk thresholds, the clinical trials, much of it was not built with a 68-year-old woman's gut microbiome in mind, or a 73-year-old man's kidney filtration rate. That is a system failure, not yours. I want to tell you about a patient I'll call Margaret. She was 71, a retired school teacher from a small town outside of Cincinnati. She had been taking ibuprofen every morning for about 3 years, 400 milligrams with her coffee before she even ate, because it was the only way she could open her hands enough to button her blouse. She mentioned it to me almost in passing. She'd stopped mentioning it to a regular doctor because the appointment always moved on before she could get to it. We talked through the protocol, not just Boswellia, but the water timing, the food, the rest. 6 weeks in, consistent every morning, no skipping, she texted me 3 words. I buttoned it myself. That's it, 3 words. But I've been doing this work for 18 years, and that text is the reason. Here is what I want you to do tonight. Take a piece of paper, actual paper, and write down your three biggest physical complaints right now. Rate each one on a scale of 0 to 10. 0 is no problem, 10 is unbearable. Put the date at the top. Follow this protocol consistently, honestly, for 30 days. Then rate them again. You don't have to report back to me, but you'll know. And knowing is where change actually starts. If you know someone, a spouse, a sibling, a neighbor, who's been quietly reaching for that ibuprofen bottle every single morning, please share this video with them. Not because I need the views, because they deserve this conversation too, and nobody may be having it with them. Thank you for spending this time with me. I'll see you in the next one.